We're live. So good morning, everyone. My name is Hina Shah. I'm a senior analyst at the Kansas Health Institute, and I am your facilitator for the morning. I'm going to turn it over to your chair, Sarah Schlitter, to welcome you this morning.
Hi, I'm Sarah Schlitter, and Kristen O'Shea and I, Senator O'Shea and I, have the privilege to co-chair this work group B, which is Access to Services Working Group for the Senior Care Task Force. Today is meeting number 5, which is the recommendation development for home and community-based services, and we have a jam-packed agenda. So I want to welcome you today on Friday, February 25th.
Thank you. And Sarah, do you want to kick us off with the word?
Sure. So I'm just excited to hear from additional subject matter experts. I really liked last meeting. I'm really excited to use the SWOT analysis again and really kind of dive deeper into kind of our recommendations and how we want to develop those. So I'm excited today.
Great, thank you. Senator O'Shea?
Hello, good morning. This is Kristen O'Shea. I'm Senator for the 18th District, serve on the Public Health and Welfare for the Senate Committee, and the word that I think of is change.
Thank you. Jamie?
It's Jamie Gideon with the Alzheimer's Association. The word I think of is equity.
Thank you. Dan?
My word would be independence.
Do you mind introducing yourself too?
Oh, I always forget that. Sorry. Dan Goodman, Assistant Commissioner for KDEDS.
Thank you. Annette?
Annette Graham, representing Kansas Association of Area Agencies on Aging, and my word is choice.
Thank you. Jan?
And Kimbrell, silver-haired legislator, my word is coordination.
And Jan, do you mind reminding the group of your other former occupations?
Once upon a time, not terribly long ago, I was a certified nurse assistant and a CMA and a rehabilitation aide.
Thank you. Linda?
Good morning, Linda Mowbray, Kansas Healthcare Association and Kansas Center for Assisted Living, representing long-term care options, both nursing homes and assisted livings across the state. And because of the nature of this group that's been pulled together, my word is groundbreaking.
Thank you. Heather? Heather, we're not hearing you. All right, I'll circle back to you, Heather. I'm sure Xavier can help you as well. Stacy?
Hello.
Oh, I hear you now.
If you can hear me, I can't. I'll keep messing with my settings. I'm Heather Brown from Johnson County Developmental Supports, and my word for today is the workforce.
Thank you. Stacy?
Hi, I'm Stacy Carson with Johnson County Developmental Supports, and my word is technology.
Perfect. Tanya?
Good morning, I'm Tanya Dorfbrunner with Oral Health Kansas. I'm also taking the word equity.
Thank you. Sean?
Good morning, Sean Sullivan with Midland Care Connection, with innovation.
Thank you. And then we do have other staff sometimes with us. So KLRD staff is Sean Marshall. I don't see him on this morning though. Is Kendra Baldridge on from KDHE? All right. And have I missed anyone? I want to make sure I don't miss anyone before I turn to our supplemental experts. All right. Well, we do have 2 supplemental experts with us. Nan, I'll have you go first.
I'm Nan Perrin with Sunflower Health Plan, and you guys all have great words. I'll use excellence.
Thank you. And Deborah?
I am Deborah Binkston with Accessible Home Care and Accessible Home Health, and my word would be access.
Thank you. Emma, besides equity, did we have any repeats?
We did not.
Terrific, nicely done. Well, let me share the agenda so you see what we have going today. And as your chair said, it's pretty jam-packed. So we'll start out by hearing from your subject matter experts. And I know you did have a few data requests from the last meeting. So I have sent those out to the MCOs and I will work with them to get that information to you before your next meeting or between your meetings. And this is around kind of average cost of plan of care per individuals and across all the waivers, average number of service units from MCOs, and then I'll reach back out to KDADS about number of beds and nursing home residents per capita, the latest comparison points. So that data will be forthcoming, but you'll hear from your two subject matter experts for the day. And I've given kind of plenty of time for Q&A if you need it. Otherwise, we'll move on to the recommendation development. And so again, we'll use that Google Jamboard, use the SWOT analysis as your basis, kind of things you hear from your experts as well. To formulate those recommendations. And then you did have a chance to really brainstorm that topic last time. And so I'll review your brainstorm kind of at the end of the meeting and anything additional you want around your next topic on senior daycare services. And then just talk about the next meeting. So that is our agenda for today. So with that, I'm going to stop sharing. And I will invite Nan to start off. And Nan, let me know if you want to share or if I should share your testimony.
You're welcome to share my testimony. That'd be great.
Okay, perfect. I will bring it up on the screen and you can start when you want to.
Okay. Chairman Schlitter and members of the working group, thank you for the opportunity to share information regarding HCBS rebalancing. My name is Nanette Perrin. I'm the Senior Director of Social Determinants of Health and Pathways for Sunflower Health Plan. Sunflower Health Plan currently has 6,554 members in our long-term care population and over 162,000 total Kansans. One of the things that's been a little bit different, so many things have been different with the pandemic, but since April of 2020, Stephanie Rasmussen, our Vice President of LTSS, has been hosting a biweekly LTSS stakeholder meeting to discuss issues related to the pandemic, as well as just all of the ways that we can move forward. This collaborative includes Representative KDADS, some of you on this call, and the other MCOs, Nursing Facility Association members, InterHab, several IDD providers, and community developmental disability organizations, as well as HCBS providers and member advocacy organizations. Through this meeting and through communications with our provider representatives and care coordinators, we are aware of the increasing barriers to members aging in place. Before the pandemic, and even more since, we've focused on 3 different areas of innovation for our aging population. The first of those being social isolation, chronic disease management, and then direct care workforce. And I noticed that was someone's word, workforce. The direct caregiver workforce issue is really impacting services across all HCBS programs, including both agency and self-directed services and assisted living and nursing facilities. We all have known, even prior to the pandemic, that there is a growing shortage of direct caregivers in comparison to the number of people needing care. The pandemic has exacerbated the need for solutions, although wage increases are an important solution for recognizing the hard work that direct caregivers do and for competing with the pay of other local businesses. Wage increases alone won't resolve the issue. We have seen a few nursing facilities that have chosen to consolidate their locations or even some that have closed. So I wanted to highlight just quickly within social isolation, we did do a pilot program with a group called Uniper that provided access to an online support community to members in our frail elderly waiver population. We also have a value-added benefit for members in both our frail elderly and our physical disability waiver population, where they can access 3 trips for social engagement in the community. And then we have a caregiver resource center and a caregiver journal to really help provide support to caregivers for individuals who are in their homes. So chronic disease management. Some of the things that we've done within that is in-home telehealth that is available for adults with diabetes and heart failure. And the goal of that is for members to stay at home when they need help and provide that help and assistance via telehealth for them to manage their chronic conditions. We do ongoing telephonic care management. Community-based health services staff can provide in-home member visits. That has been a little different with the pandemic. Most of that we have been doing telephonically for now, but in the situation where a team or our care managers have identified the need, even during times when we are not doing regular in-person visits, we are doing those in situations that warrant that in-person interaction. Assisting members with accessing food, shelter, and other health or social programs. That is another thing that our community health workers really do is, work with the members either in their home or telephonically to make sure that they're getting access to those social determinants of health items that they need. Another area that we've seen across all of the waivers, as I mentioned above, is that direct care workforce. We did do a emergency backup pilot. We collaborated with the National Centers for Independent Living and completed an emergency backup plan for direct care workers and also Centene. And for those of you that participate in the LTSS biweekly meeting, the National Advocate did share that review of effective backup plans and what might make that more efficient with keeping people able to age in place. Someone shared the word technology. Expanding uses of technology is definitely an area that we are seeing as something as we move forward with innovations as being necessary. We're currently working with 2 in-state providers and 1 out-of-state provider that offer a combination of smart home technology and 24/7 remote monitoring to support individuals in their homes and communities. So, and really we're collaborating on how they can partner with us to offer technology solutions at both the provider and the member level. And currently looking to determine a pilot we can engage in to determine and report the outcomes that can be achieved. Expanded use of technology within the HCBS waiver programs will also potentially help free up caregivers who then can be hired to work with persons who need in-person care. So it's kind of, it helps both the individual who's accessing the technology, but then also potentially increases bandwidth for someone who whose needs are more for an in-person interaction. Family caregivers. So during the emergency order, KDADS gave expanded flexibility to approve for family members and guardians to be paid for those home and community-based services. And really the high-level feedback within our stakeholder group is about the potential value of continuing some or all of that flexibility to expand the pool of persons. So a suggestion was made to evaluate the option of offering a flexible subsidy to natural support family caregivers who do not receive other pay. So we plan to continue working with stakeholders to evaluate the need for future flexibility with appropriate guardrails and to make recommendations to KDADS. In 2020, Centene, which is our national group, also purchased a platform for advancing states for matching caregivers to jobs and for providers to use to manage workforce needs. Advancing States is the National Association of State Aging and Disability Agencies. Currently, 7 state agencies are using the platform, which is called Connect to Care Jobs. Advancing States is in the process of making improvements to the platform and plans to offer it to more states before the end of the year. Thank you again for the opportunity to share the information, and I'm happy to answer any questions you have.
Thank you, Nan. And before we go into questions, I just want to remind us of our meeting commitments. So come ready to discuss and compromise. Keep your remarks succinct and on topic. Don't hesitate to ask clarifying questions, and I'll make sure we start and end on time. And before you ask a question, if you could identify yourself just for those watching, that would be helpful as well. So any questions for Nan?
This is Annette Graham, Kansas Association of Area Agencies on Aging. Hello, Nan. I have a couple of questions. You referenced at first a number for your long-term care population. Is that the nursing facility residents, or is that all older adults?
So that includes our nursing facility residents as well as frail elderly population and PD.
Okay,
both in
thank you. And you talked about Juniper and using that for social engagement, and also the technology project you're working on. Does Sunflower cover the cost for the internet access for your members?
So at this time, we do not. We have in pilot situations, so with Juniper for members that did not have broadband, we did do that. And for our telehealth solution that is chronic disease management, then we do provide that internet access for that, that technology. We do work, our community health worker teams work with our members to connect with the federal program of SafeLink to try and ensure that we have that, and have partnered on some other innovations in regards to broadband.
Okay.
Always looking for more opportunities.
On your chronic disease management, are you certain diseases that you've identified to be in that program?
Yes, it is COPD and congestive heart failure. Nice to see you, Annette.
Questions from other members?
Yes, I have a question. Nan, this is Deborah Binkston with Accessible Home Care. I hear a lot of great things in your presentation today, but as a provider, I haven't seen any of this information. What methodology are you going to use to share it with providers so we can work with you to meet the needs of these people in your program?
That is a great question. So as I mentioned, the LTSS stakeholder groups, we definitely would welcome if other providers want to participate in that. That is one option. And I will talk with our provider relations department to make sure that they are also sharing that information.
Thank you.
Sean Sullivan, Midland Care. Nan, what do you see? I mean, you talked a little bit about social isolation, chronic disease management workforce. Would you attribute one of those or other factors as kind of the maybe biggest, largest one or two reasons why people can't stay at home that are Sunflower members? So what's the trigger that causes them to no longer be able to stay at home in your mind? What is the barriers?
Sean, that is a great question. So there's a little bit of a combination. So in some situations, it is that a member goes to the hospital and so their needs change and we aren't as quick, or it is a very quick solution. I don't know if that's the right way to put it. But the member then goes to a nursing facility and loses maybe some of the resources that they had previously because of that change in condition and maybe not a quick enough response to that. I think other than that, it really is that workforce and that ability to get supports and services at the right time and the right place.
Any other questions from members? I don't see anything in chat.
Heather Brown, Johnson County Developmental Supports. As you guys are discussing these things, I know that social isolation is a big deal. Have you, in your discussions, talked about the potential for additional technology to further social isolation? I know that it could help greatly with workforce and, you know, kind of stretching our resources, but then again, there's that other side of it. So I was just curious to see if has been a part of your discussions.
It has definitely been a part of our discussions, and I know that, again, during the pandemic, we did receive some resources and worked with some groups to try and both with Uniper and then also with some tablets to try and ensure that utilizing technology for the social isolation, again, because of the uniqueness of the pandemic, and we didn't want to send more people in. But we continue to have that conversation of, you know, what are other strategies that will increase and what are other potential partnerships that we can have with providers in the field to make sure that we're addressing both the workforce, but also just that real issue of social isolation for many of the individuals in the aging population.
Thank you.
All right, I think we have time for maybe one more question if anyone has one.
I'll take it. This is Sean again. Hey, I don't know whether you're able to answer this, Nan, but there's been this issue kind of going back probably 15 years around HCBS reimbursement rates for assisted living and facilities. Long-term care associations would say, hey, if you paid us, the state or MCOs paid us a higher HCBS rate, we can provide the room and board, the housing, and at least be in a less restrictive, lower cost environment than nursing homes. Do you all do that based on, my question is, do you all do separate case rates, separate of what the HCBS reimbursement rate is to incentivize assisted livings for that room and board rate to be able to keep your HCBS members in a lower cost setting? And if not, why not do that more? I don't know if that makes sense as a question. It made sense in my mind, but not as it came out.
Sean, that question does make sense. And we do have specific situations where, based on a member's need, we may look at other ways to support that staying within a lower, within a less restrictive environment. That is obviously always our goal, is to help individuals to stay where they are, but kind of those are handled on an individual basis. We have also talked a lot with some of the other states in which we work, in which our colleagues work. I am Kansas specific, but and really talked about the fact that Kansas has a unique funding mechanism that is not the same as many other states. And so really talking about, many assisted living facilities in Florida, for example, they receive a daily per diem similar to a nursing facility versus the way our assisted living facilities are supported oftentimes for individuals on the frail and elderly waiver. It is with a number of specific hours that they receive to support that member's activities of daily living. So I think we continue to look at both what we can do in individual one-on-one cases, but then also at the opportunity if there are other ways to look at providing support to encourage those levels of care. If that answer makes sense. It may make less sense than your question, Sean, but I understood your question. So.
Thank you, Dan.
Sure.
All right, well, thank you, Nan. I'm going to invite Deborah now to say a few words about from a provider perspective.
Good morning. Thanks for letting me speak today. I'll keep my introduction short so I have time for plenty of your questions from the provider perspective. I own Accessible Home Care and Accessible Home Health. Main office is based in Salina, but we have 4 locations and serve about 32 counties in Kansas, and a lot of it significantly rural. We work with FE, PD, DD, and brain injury. Have been doing so for about 25 years. So that's our home health side. We also have a second company, Accessible Home Care, that is Medicare certified and provides skilled nursing visits, skilled therapy visits to the elderly population also. From my experience, for rural Kansas, it does come down to being able to get those the direct support workers hired Very, very challenging because the cost. You've got to pay travel time and mileage. It's not unusual for a team member to drive an hour between patients, and there's no reimbursement for that from any of the programs. So travel between customers is significant in the rural areas and running our cost up. We did work with all 3 MCOs and were able to renegotiate our hourly rate with 2 of those. So that was very helpful for us to be able to keep people on service. I can't understate how much COVID has impacted our ability to provide care. There's people that in the past would have been willing to provide these services, and COVID kind of scared them out of the workplace. These people tend not to be medical backgrounds, the attendants. Having to go to work in a half mask, a gown, gloves, really made them feel like this is a job I may not want to do when I can make the same money or better money at Target or Sonic, anywhere else. So that really impacted our ability, plus all the extra government money, the stimulus money, the extra unemployment money, that really made it where people could make more money staying home than they could working for us or in an attendant care capacity for anyone. That's begun to improve. We seem to be hiring again late January, early February. Hiring's finally picked up to the highest it's been in the last 2 years. So we're hopeful that will continue. We are competing with nursing homes that are paying nurses' aides as much as $25 an hour with some of the federal money the nursing homes and hospitals received that we in home health and independent care did not receive. So it's very competitive. People have to do this because they believe in helping others, not just for the pay. And that's hard when you're supporting a family. Another concern I've seen since we switched to the MCO system is lack of use of wellness monitoring for the FE and DD waiver patients. Wellness monitoring is the RN visit every 2 months to go and check on a patient. Are you getting to your doctor's visits? Are you taking your medicines properly? Are you getting your needs met? How's your health care going? And as we talk to the MCOs about this patient needs wellness monitoring, me and the case managers aren't even aware of what that service is. I feel like those nursing visits are very important in keeping members in their home and giving a little bit of medical care at a very low cost. And that service is not being utilized at the same level it was prior to switching to the CanCare system. I forget how many years ago now. Another concern we've seen is, in my opinion, it's strictly my opinion, sometimes a misuse of the self-direct programs. If we are unable to service a client or unable to negotiate a rate with an MCO, they just switch them to self-direct. And many, many times these customers do not have the capacity to self-direct. They have dementia, they have confusion, they have lack of family support. And if they can't find a provider, just put them on self-direct and let the patient figure it out. And that's been a very disheartening transition to see happen. When you've been in healthcare all these years, you've got to do it from the heart. And to see these people expected to administer their own care, to hire their own workers, to be able to hold employees accountable at this level, they do not have the capacity. So the misuse of self-direct services since we've been under the MCO system has been pretty much heartbreaking. So the good thing is we work really, really hard to combine the forces of our 2 companies, as I know other providers do, to keep people at home. If we see needs with our long-term services patients that we can support with the medical side on the medical card, nursing visits, therapy visits, home health aid visits, if appropriate, then we add those services and try to keep them at home as long as possible. So with that, I'll try to be quiet and answer your questions.
Thank you. What questions? Go ahead, Linda.
Hello, Linda Mowbray, Kansas Healthcare Association. Appreciate the presentation and wondered if, since 2013, Sunflower has been here all along. United Healthcare has been here all along. The changeover of the one company was a little bit of a glitch in the system. Are you noticing the self-direct avenue being utilized by one particular MCO over another, or is it fairly uniform across the board?
Oh goodness, that's not fair to say. I will just say that Aetna and United were willing to negotiate rates with us to a significant improvement across the three waivers to keep their people having the home health services. For the benefit of having a home health agency instead of self-direct is you get the support of the office. If somebody calls in sick, we're sending another worker. If you're self-directing and somebody calls in sick, you're just without help for the day. So you have additional support. We have liability insurance, professional practice insurance. We can get these needs met. We have a scheduling system. It takes that away from the patient, that responsibility, and gives them a lot of protections. And so I know that many of the clients for the one agency that we were unable to self-direct with, it was a very quick decision by the case manager to move people to self-direct. And I felt strongly that many of them did not have the capacity to self-direct.
Thank you for that. When you refer to the negotiating rates, is that more of a single case agreement then? Is that how you're looking at that, or is that just?
It was in the beginning. The two entities have come back now and just changed our rate across the board. So that's been very helpful to reduce the administrative burden.
Any other questions? Well, Deborah, thank you for your time. You are welcome. You're welcome to stay on while the group begins developing their recommendations as they have questions. But I won't hold you if you have other meetings and things to get to. So thank you.
Thank you.
All right, members. So we are going to go to that Google Jamboard now. I'm going to share my screen, and Emma has dropped it into chat for you. And again, you are going to first, go through kind of the 4 boards and then a 5th catch-all board for recommendations. As you're developing them, feel free to chime in on your intent, or if you want to share a recommendation as you're going forward. Let me know, first of all, if this is big enough, and if not, I will try to make it bigger. I'll at least get it to 100%. But our first board is on using strengths to take advantage of opportunities. And so I know there's a lot of opportunities in here, so I think I'm going to have to actually shrink it back down. All right, we're just gonna have to stay at that. Let me know if that's too teeny tiny. Remember, you do have this in your meeting notes as well. And friendly reminder, you just simply click on it, type your recommendation, and then press save, and it will save. I'll change that though. And so with that, go ahead and start developing recommendations and adding them here. If you have any trouble at all developing these, feel free to put them in chat, and Emma or I will turn them into a sticky note.
And
So with
Graham,
that,
you
yes,
have a
go ahead.
question at Graham, Kansas Association of Area Agencies on Aging. When we're talking about home and community-based services, I just want to clarify, or we're just talking about the Medicaid home and community-based services, the waiver programs. There's 2 different ways to use that terminology. So are we just talking about the Medicaid waiver program?
So your whole topic is on rebalancing HCBS services. And so it is talking about that and having.
Okay, thanks.
Yep. All right, I see a few recommendations getting drafted. Providing funding for coordination of services for home-based seniors in a community. Collaboration between HCBS programs to increase accessibility and share resources. Market the statewide ADRC Resource Center phone number to access information. Maybe take 2 more minutes. And of course, you can keep adding recommendations even if I move to the next screen. Establish rural PACE programs in closer proximity to the actual population of those needing home-based services. All right, would any members like to share or provide clarity or intent behind their recommendation? Establish a pilot for rural PACE program. Explore technology to assist people. Another one around technology. That was one of your words too.
Annette Graham, the Kansas Association of Area Agencies on Aging, and I put the one about fund the money follows the person program. The association, the Area Agencies on Aging, had gotten a grant from the Administration for Community Living that was COVID related, and the goal was to transition 30 individuals out of nursing facilities back to the community. We started that program. The first transition was December 21st of 2021. We have now, the program is continuing through September, and we have now transitioned across the state a total of 46 individuals from nursing facilities. We've worked with MCOs and partnered with them for individuals on the waiver programs. They don't have to be Medicaid, but they can. Some of them have been private pay, but it has been very, very successful. It has looked at social isolations, community support, and social determinants of health, and has been very cost effective, providing follow-up for 12 months for individuals transitioned out. And we've also worked with Assistive Technology of Kansas to utilize technology to help that individual. So we know that this can be done very effectively and very cost effectively to get those people back to the community for people that choose to return back.
Thank you, Annette. And Linda, did you still have your hand raised from before, or did you raise your hand now?
Linda Mowbray, Kansas Healthcare. Now, this is a new comment. This is my comment that I dropped in, or recommendation, is that about 15 years ago, we had a pilot study with the state of Kansas where we looked at individuals that were on the FE and PD waiver in assisted living and Home Plus. We cross-referenced those individuals with their care score, their level of care that they were determined. to have when they came in the facility and then on their annual review. From there, we were able to create sort of a grid, if you will, that had 3 different levels of care, 3 different payment levels, if you will. Now, this was pre-can care. And with that, we were able to see a range, and we felt like we were making really good progress with that. And I'd recommend that we take up that kind of thinking again so that there's more uniformity across the provider network with, if you have a score level between here and here, it's X amount of dollars. So that's my recommendation.
Thank you. All right. Well, I'm going to move us to the next board now. And so in this board, you're going to overcome weaknesses by taking advantage of opportunities. So take a look at both boxes and see if there's any recommendations that come to mind when you want to think about overcoming some of the weaknesses you've listed by taking advantage of opportunities. And you yourself, if you want to just double check, you can always go back and forth between boards. So take a few minutes to develop recommendations here. And again, feel free to drop them in chat if you're having any trouble putting a sticky note together. We've got a few recommendations that are being started here. One is allow services to be provided to anyone receiving HCBS services regardless of which waiver.
Still not good?
I don't know who is speaking, but perhaps go on mute.
I don't think it's that medicine, and you didn't take it again, did you? See that? No.
Robin? All right, I think they are on mute. Sorry about that. All right, would anyone like to share a recommendation or provide a little more clarity or intent behind it? When you're developing recommendations around overcoming weaknesses by taking advantage of opportunities. There's a few on
Twitter.
Go ahead, Sarah.
Twitter from Johnson County Developmental Services. And I put continued flexibility just shown during COVID, because I think we have seen some really good strengths and really good, probably flexibility in terms of programming. And I'd like to see that continue post-pandemic.
Thank you for sharing. Any others? I see use federal funding to increase rates for personal care services that can increase pay in expensive urban areas and mileage pay in rural areas. And we can do this later, but if you have specific federal funding sources, adding that to the recommendation is always helpful, just specificity. We will go through making each of these recommendations actionable before prioritizing them, and so we can always capture the information then as well. All right, well, I'm going to move us on to the next board. And if you're still finishing up, you can still finish up. The next board is looking at the strengths that you put together and using those to avoid threats. So take a look at that. Take a look at both of your boards on strengths and threats and what strengths can be utilized to avoid threats. Any recommendations in that area come to mind? So I see a few recommendations here. Would anyone care to share? Provide more clarity or intent behind your recommendation? All right, expansion of pace could address many of the threats, and that's one that we've seen. Thank you, Nan. Educating local staff of private as well as public services to programs available to seniors to enable home-based care and services. Leverage the increase in protected income level to mitigate any costs associated with coming into compliance with the final settings rule. For that one, would you like to expand on that? Does everyone understand this recommendation?
Mowbray, Kansas Healthcare Association, that was one of my recommendations. The increase in the protected income level as it's used in assisted living and home plus, goes not on the care side the individual receives, but for the room and raw food portion. Since it went from 717 up to 1700 to I think it's 2523 now, that has given additional revenue streams for room and raw food to the assisted living and home plus, instead of having to request the family to help make up that gap, or simply not being compensated for that gap. So if we are able to educate individuals on individual providers on how to look at this, so that if they do have to put a new doorway in, or if they do have to have a new system in place to come into compliance with the final rule, that they can see how those dollars that were not available before might be used to offset some of that.
Thank you. Would others like to share their recommendation or intent behind it? Otherwise, I'll move us to the next board. All right. The next board is minimize weaknesses and avoid threats. So this is your double negative. Let's look at these threats and weaknesses and really try to minimize those. What are some recommendations around that? Any recommendations in this area? Oh, I see a few. I'll give you a few minutes then. All right, balance the rates among the waivers. Increase service flexibility. So I'm seeing some similar themes across the recommendations. Again, if someone would like to share and provide more clarity or intent behind the recommendation, I'll invite you to do so at this time. All right. Now this last screen is kind of a catch-all. Any other recommendations that has come to mind for you around rebalancing HCBS? This is your catch-all board. I've got two screens going, so I apologize if I keep turning my head. I promise I'm paying attention to you. All right, ensure services that are available under the FE waiver are also available to people on the IDD waiver. See a few more. One that I'm adding from the chat. Advocate for mileage reimbursement to make driving long distances between for patients in rural areas feasible. Give you maybe 2 more minutes to finish up on this board. Promote the new directions for senior opportunities for living within all communities across the state or through medical clinics and health departments where seniors would see and learn about their options. I think it's even longer. And take home flyer to learn more about it, numbers or addresses for more info. And then the other one is invest in housing options to increase the availability of accessible, affordable housing options for older adults. All right, well, I see a few might still be adding increased collaboration between waivers and programs. That's a common theme we've seen across these recommendations. Feel free to keep adding to these and we will summarize them in your meeting minutes. So keep on adding them as you're thinking them through. Educate members through the ADRCs about HCBS. I have another one I'm adding from chat. Education to providers on wellness monitoring to increase its use as low-cost medical care. All right, I'm not seeing any other activity, but feel free to keep adding and we'll make sure we summarize it in your meeting minutes. All right. Well, strong work there, and we are a little ahead of schedule, so we're going to think through a few things now. So first, your next meeting is going to be on adult daycare services, and so you did brainstorm some data and experts at your last meeting. So I did want to review those and ask if there's any additional information that you wanted. So the way I have it is from KDADS, you wanted to hear about licensing requirements, a number of adult daycares that have opened and closed in the last 10 years, describe barriers with licensure processes for working groups to see what there is and what else is possible. And then a data request was how many people currently use HCBS services or are being served in adult care settings. The other one that I have is for PACE organizations, and I know Sean's on here, so I'll definitely reach out to him as well, but study your information on senior centers also being used as an adult day center with PACE model for rural communities. You also asked for an HCBS IDD provider to speak about their experiences in running HCBS day services. And then you also asked to have all 3 MCOs invited to be present as subject matter experts. I think it would be helpful for those MCOs to have some direction though, so are there specific questions you would like for them to address? Otherwise, they can be present and provide kind of a general overview of what their plan covers, if that is what you are looking for.
Sarah Schlitter from Johnson County Developmental Supports. I'm interested in just kind of talking through or seeing their viewpoint of what their service delivery models look like post-pandemic, because a lot of times they have spoken about increased flexibility. So that would be nice.
Thank you. Any other questions?
Linda Mowbray, Kansas Healthcare Association. My question is again a data point. The KDAD's adult care home directory shows if a nursing home is licensed for adult day beds. Same with assisted living and home plus. But I don't think we have any data points as to how that's actually being utilized. So we may know that there's X amount of providers out there, but are they currently accepting day clients in their services?
Thank you. And this is to ask the MCOs, correct?
Linda Mowbray, my apologies. That would be another data point for KDADs, although it might be that the MCOs would be able to provide that information on their own particular clients.
Okay.
This is Dan Goodman, KDADS. I think you also, and you may have already mentioned this, but I don't recall that you did. We also wanted them to speak to the average plan of care cost and cost of waivers. So that would be one of the questions as well. And those, and then those that have transitioned during the pandemic in the community. Yeah.
Yes, I have those two as well.
Great.
From their previous conversation.
Stacy Carson, Johnson County Developmental Supports. I've always been curious to have an idea of the number of senior day programs that are specifically for those with IDD in the state of Kansas. Is there any way we could get some information about that?
Dan, would that be from KDADS?
Yeah, I think that may be, I'm hoping that Lacey Hunter will be the one that's speaking on those issues. So I'm hoping that she'd be a presenter that could probably speak to that next time as well.
Okay. All right. Any other speakers or?
Yeah, I think that there is a adult daycare here in Wichita that has been providing adult daycare for many, many, many years, that I thought that we might be able to ask them to come and speak and talk about their services. They provide, one side of their program is for individuals with physical disabilities, one side is for older adults, and that is a well-functioning program, so I can get you the information on that. And then I did just have another comment. I think as we get speakers and ask for presentations, that it's just important that we keep our focus on those individuals 60 and older at that higher level, and not kind of sometimes it feels like we kind of dive down into some younger populations and issues that impact. But I think because the focus of the Senior Care Task Force is age 60 and older, I think it's important that we just keep that focus. Just a comment.
Thank you. And then one comment that I saw was ask AAA if they believe they can talk about some of their senior services through their centers that are in the smaller rural communities. Instruct their site managers to also be aware of services and provide the current printed information readily and regularly. So I will see if we can reach out to them. All right. Anything else on this topic? I am going to ask you to brainstorm your next topic as well. All right. So your last topic, your work group actually has 4 topics. And so the 4th one is funding and implementation of the Kansas Senior Care Act. So in thinking through that topic area, what, besides having the document, the legislation, the Kansas Senior Care Act, what additional information or experts do you want to hear from? For example, would you want someone from the revisor's office to go through the Kansas Senior Care Act? Would that be helpful for this group? Or would you like to have other experts come in and talk about how they use the act?
This is Dan, KDAS. I believe that a good subject matter expert to come and speak would be Leslie Anderson of K4ED. The AAAs are who provide this service across the state, so it'd be good to hear from them.
Okay.
Linda Mowbray, Kansas Healthcare Association. I'm not sure who the presenter would be, but the rebalancing savings that we're hoping to see, or that we have seen, what would be a ballpark of that amount and the mechanism to funnel that back into Senior Care Act to bolster? And I don't know if that's revisor or whom would have that information.
I'll look into that. Thank you, Linda. Any other experts? Any other data? So that's kind of a data point there. And we may have a slightly different format for some of these. For that meeting, it might be that you hear from your experts kind of the first half of the meeting and you develop recommendations the second half of the meeting. I may do that also for the next meeting, depending on how long the Q&A goes. We may even start developing recommendations on adult day services as well, just so you have lots of ample time to really prioritize and characterize your recommendations. So again, thinking through funding and implementation of the Kansas Senior Care Act, any other data points or experts come to mind? And I'll start reaching out to them so you have that information.
This is Tanya Dorf-Bruner at Oral Health Kansas. I'm a little bit on the edge of some of these issues. So I feel like your suggestion to have maybe somebody from the revisor's office talk a little bit about what the act is and kind of and maybe it's the revisor, maybe it's legislative research, maybe it's KDADS, but talk a little bit more about the history of it and the kind of and how it's designed to work would be helpful.
Sure. So an overview. All right. Any other data points around it? Any information you want to know? All right. Okay. Well, as we close, I want you guys to reflect now on kind of the work we've done thus far from January to February. Remember, we're trying to kind of each month focus on a topic. These next two topics will be a little quicker, where we'll take a meeting to focus on each topic and develop recommendations. But maybe the experience thus far and what you want your working group members to really keep top of mind, like Annette mentioned, you know, that population group. What are other things that you really want the members to keep top of mind as you're developing these recommendations? And really when you start prioritizing these recommendations for the task force, because everything can't be a priority, right? So so you will go through some exercises to really prioritize. So what do you want the group to really think through as you do that? And before we go around and do that, know that your next meeting is on March 11th at 9 a.m. So keep that in mind. There is one conflict on May 6th. Is it okay if we move the meeting to either May 13th or May 27th? So look at your May calendars. And if we move that meeting from May 6th to May 13th or 27th, would that be an issue? And I can put the calendar up if that's helpful for you as a visual to look at.
This is Sarah Schlitter at JCDS. I would be available May 13th.
Okay, this is the one I'm looking at. May 13th? Anyone have issues meeting on May 13th instead of May 6th?
Hi, Anna. This is Kendra Baldridge. May 13th actually wouldn't work for me, but if it works for everyone else, feel free to go with it.
This is Tanya Dorfbruner at Oral Health Kansas. May 13th is not good for me either, but like she said, if it works for everybody else, that's fine too.
How's May 27th looking?
Stacy Carson, Johnson County Developmental Supports. I would not be available on that day.
May 27th? Okay.
And Kimbrell, silver-haired legislator. It's Memorial Weekend, right?
Ah, yes, you're right.
So
All right.
I'd be unavailable that day.
Okay.
Thank you.
Okay. Well, I will work with the chairs and see if the alternative date makes sense. Otherwise, we'll keep going, and maybe in June we can throw an extra meeting in as well. All right.
This is Annette Graham, the Kansas Association of Area Agencies on Aging. And I'm just wondering if it might be a good content expert at the next meeting, like somebody from AARP to talk about, like they do a national scorecard on aging services, and they have information on like the older adults and where they choose to live and where they want to get services. And I just thought he might be a good content expert to come and share some of that information that might be helpful as we're looking at Senior Care Act, since it is a community-based service program.
Okay. That's for more Senior Care Act and not Adult Day Services, correct?
Yes, yes.
Okay. Can you remind me his name again?
Ernie Cutsley.
Yes.
And he is on the task force.
He is. He's in Working Group A.
Yes.
So I will reach out to him.
Thank you.
All right. Any others before we have closing remarks? Well, as you guys have been talking, Emma has been compiling some of your recommendations in here. So you have quite the list in here that we will work on consolidating so that we can work through your characterization and prioritization exercises. All right, so I'm going to go around Robin again and call on you to maybe give some last remarks. Really what you want members to keep in mind is you're kind of midway through the process almost. And so Kendra, I know you joined a little late, so I'm going to start off with you.
I don't have any additional comments, Hannah. Thanks.
All right, thanks, Kendra. All right, next, Jamie.
I wanted us to continue keeping in mind the rural areas and access to services in there.
Thank you. Dan?
Kind of piggybacking on some of the comments that Annette made. I think it's, we've been pretty focused and specific in certain segments of the aging population. I think it's also important to kind of to pan out a little bit and look at the broader aging community and how we can meet the group as a whole, the needs of them a little bit better.
Thank you. Jan? Jan, I think you're on mute. I'm sorry.
Yes, I'd like to keep in mind that the senior population increase is now, and we are living in it now. It's not 10 years from now. We're in it now. And so if we can focus a little bit on instead of so many pilot programs, let's put something in that addresses us now, because some of us may not make it to the 85 that I've heard about. But I'm hanging in there at 67, so I need some services. Thank you.
Hey, Jan.
Linda?
Linda Mowbray, Kansas Healthcare. I do think that to reinforce what Dan Goodman was saying, I think there are many different senior needs, and making sure that we are focusing on the needs of all seniors, whether it's because of dementia-related illnesses, physical illnesses, the social isolation, just that there are many needs out there, and not to get tunnel vision.
Thank you. Annette, did you want to make other comments as well?
I'll just say innovation. I think that we're looking at a changing demographic. The needs of older adults change as we move forward. It's a different generation we're serving, and we have to be creative and innovative in how we meet those changing needs.
Thank you. Senator O'Shea? Oh, she may have dropped off. Sarah?
I would just say, like somebody else had mentioned, we're going to see just more people aging and living longer. And so really thinking through how can we utilize technology as well as some different service delivery options to meet those needs.
Thank you. Heather?
Yes, Heather, Johnson County Developmental Supports. I would just like us to keep in mind what we already have available, what's there, and maybe take our recommendations or see what we can do to just enhance what we already have instead of, reinventing 5 different wheels. So just keeping in mind the assets and things we have in place now and how can we enhance those.
Thank you. Stacy?
Stacy Carson, Johnson County Developmental Supports. I was kind of on the same thought process as Heather Brown in keeping in mind the resources that we already have and utilizing those to like a larger extent. Like let's say senior daycare programs that have individuals with IDD, participating in them, vice versa, using those PACE programs for, individuals across all waivers. Thank you.
Thank you. Tanya?
I've been thinking about this a lot lately in a lot of contexts. I think it's important to think about just how the world is, how not the world, how we're all going to be different on coming up as, we're theoretically coming to the end of this stage of the pandemic. I think the way work happens, the way people live, the way everything happens is just different. So I think that the issues around technology, about meeting people where they are, I think they're just more important than ever. But I think, I guess the peanut of what I'm trying to say is how do we maybe just not get stuck in how we've always done things, because I don't think nothing is gonna look the same anymore. And we just have to accept that and be creative. It's an opportunity.
Thank you. And I think Sean may have needed to drop off. So that is everyone on this group. Well, thank you all for being here this morning. Thank you for the grace for the late start, but it looks like we caught up. I will see you again on March 11th. And again, this is Hina Shah from KHI. Take care, everyone. Have a good day and weekend.